For the Young at Heart is sponsored by Duville Life and Wellness Community, a commitment to care, a legacy of compassion. This is Duville.
Hello, welcome to For the Young at Heart. My name is Lucille Jerome, and on today's program we're going to be taking a look at the importance of dental care for senior citizens. My guest today is Dr. Gregory Ross, and he has a practice in the greater Lowell community. And I'm so glad you could come today.
Thank you. And thank you for having me. It's a very important subject.
Yes, it is. For our audience, for me too, why is it so important for dental care for senior citizens?
As for anybody else in the population, the whole idea behind dental care is early intervention, really trying to catch things when they're small, before small problems become big. So whether it's, detecting, gum disease issues or maybe decay in a patient, trying to avoid, an infection that might occur in the mouth due to negligence or neglect, we want to, stay at top of those things. And just, other things that come into play are oral cancer screenings. Early detection is really what keeps dental outcomes positive.
Okay, so that's part of the screening, oral cancer?
Yes, definitely. A very important part, probably one of the most important things we do.
Okay.
Yep.
How frequently maybe there is no should, but how frequently is it recommended that a senior citizen see a dentist?
Well, our normal population, I would say twice a year, okay, and the same thing for seniors. In terms of oral cancer screening, at least once a year. Great concern to me are patients that wear dentures and they kind of disappear, we never see them again. They really should have an annual exam. We have other patients that have ongoing needs that necessitate further care. You have people that have gum disease that might be seen every 3 months for intervention. You have some people with high incidence of, say, root decay that might need closer intervention as well.
So there's no limit in terms of age as to what particular problem someone might have with their dental care, with their mouth care?
Not in particular, but there are things that definitely seem to impact seniors potentially more specifically.
Ah,
and
okay.
So, as a function of time with a lot of patients, the largest percentage of patients population we see that have gum disease are the elderly population. And there are some other things that come into play that are a little bit more of a risk factor. As we age, if the gums recede, seniors are more prone to getting root decay. And some other lesser factors can just be discoloration of teeth and, how people feel when they present to the world, what they want to do to kind of, augment the smile that they have and, what they want to present to the world and how it makes them feel. So it's not all just on the, more negative aspects of just like, physical intervention of what we do.
So there's an aesthetic factor too.
Oh, definitely.
Health and aesthetic.
Definitely.
Talk a little bit about some of those issues in particular. For example, the discoloration of the teeth. How does that happen?
How does it happen? Well, some of it can be extrinsic, just your dietary intake. If somebody's a big fan of red wines, they that may have a little impact on the teeth over time. But as
so then, do you recommend white wine?
It might be the better choice. That could be. We don't want to eliminate wine.
Okay.
Especially in the senior years.
Okay.
Some of the other things that we're dealing with are, say, as we age, say, periodontal disease. Periodontal disease is something that can affect our whole overall health, our systemic, health. Patients who are, have active gum disease are more at risk for heart disease, stroke, and So that's also one of the things that we're really trying to arrest. If we see that, we want to tell patients how they can better care for their mouths, and also, what are the things that cause gum disease. The major factor in gum disease is improper hygiene, just extra plaque on the teeth.
Okay.
And so we want to work on the home care, but there can be other factors too. We usually delve into the patient's social history. The biggest factor unrelated to home care in terms of disease progression is smoking.
Smoking.
Yeah.
That affects the teeth?
Definitely.
All right.
With respect to gum disease, a smoker is 3 times more likely to lose a tooth than a non-smoker.
Okay.
And so, that's another thing that we want to kind of address and try to minimize the impact. So.
Would smoking discolor teeth also?
Definitely.
You mentioned red wine earlier,
Right,
but
yeah.
that?
So some of the things that discolor teeth, whatever enamel we have day one when our teeth are rough, that's as much as we get. Enamel is the strongest substance in the human body. But unlike, say, bone, which is a very strong substance that regenerates, the enamel that we have is all we have. So if we lose the enamel, you're going to have a little bit more discoloration of the teeth. And the other thing that comes into play is the underlying part of the tooth that's between, say, the enamel and where the nerve resides is the dentin. And as we age, we actually have more dentin. And you might say, well, the tooth is a certain size, how do you have more dentin?
Right.
Well, every time we experience, say, some sort of trauma or daily intake of like hot and cold beverages, the nerve chamber actually closes off a little bit more over time. So if you were to take a look at an x-ray of somebody in their 20s and you look at the size of the nerve chambers, it would be probably, versus someone in their 80s, it might be a third less the size. So what happens is more dentin gets deposited, and the dentin is not as bright as the enamel. So internally there's something that happens with the teeth.
So that's why when I'm with people sometimes and they're saying something like, my teeth seem more sensitive now than they used to. That's part of the reasoning why?
Yeah, actually that's usually due to loss of enamel. There's multi-factors for why that could occur.
Okay.
It could be something as simple as a chipped tooth where you have an exposure to that second layer of the tooth that communicates more fully with the nerve of the tooth. And the biggest thing I find for seniors is if there's any sort of gum recession and the roots are exposed, the roots are unlike the top of the part of the tooth that we call the crown, and that there's no enamel. And enamel is what kind of insulates the tooth from thermal sensitivity.
Okay.
Yeah, so
is that the beginning of what you said earlier, periodontal disease?
it can be a component
It can be
of
a component.
Yes, yeah.
Okay.
So what
Right.
ends up happening is a lot of people get a little confused between 2 terms that float around. One is gingivitis and the other is periodontitis.
Okay.
And a lot of people question, like, which one comes first? And I always say the G comes before the P. So,
Okay.
So basically what gingivitis is, it's an inflammation of the gums. So, if somebody's seeing their dentist and we're doing our assessment, we've looked at their, x-rays, we've looked in the mouth and taken our measurements to see how the gums are doing. In gingivitis, you would expect to have all the supporting structures there, meaning that the gums are in good health, the bone support is pretty much perfect, but it might just be an irritation. And gingivitis is not gum disease. It's just something that it's an environment that could set up, the potential for having a periodontal condition. So when somebody actually has gum disease, what has happened is they've lost the gum tissue or part of the bone that supports the teeth.
Part of the bone.
Yeah.
Okay.
So pockets form around the teeth, and there's more potential for your just daily food intake to kind of get stuck between the teeth, and it's kind of an ongoing process if you don't kind of reduce the pockets and get people back to health.
So part of the care is not just brushing the teeth or the dentures, but flossing in between also.
Definitely.
How regularly do you recommend that when someone is older
Yeah.
versus someone younger? Or is that
It's
not a
exactly
differential?
the same. The home care is the same for everybody. And in generalities, we want to see people brushing twice a day and at least flossing once a day. I prefer that people floss their teeth at night, and the reason is our mouths tend to get drier at night. And in a drier environment, we're more likely to experience decay and negative consequences. So that's what I usually advocate. But, patients who have gum disease, we may have them step up their hygiene. We may want to have them, brush a little bit more frequently. We might want to have them floss a little more frequently.
Okay.
And there's a lot of adjunctive therapies that we can actually put into place. We might have somebody use a water pick or something going beyond the floss that might be something that would be more helpful to them.
Okay, adjunctive, that's a good word. I'm thinking now in terms of people who might have arthritis, who don't have the flexibility they had when they were younger. So they might be trying very, very hard to brush and floss, but it's
Correct.
difficult.
Correct.
What might there be to help someone like that?
Yep. So sometimes, depending on the patient, electric toothbrush might be helpful if they can't use the proper brushing technique. We usually, when patients are brushing, we advocate that they don't scrub back and forth. Scrubbing can kind of damage the gums, and that they use a soft toothbrush. A stronger toothbrush like a medium bristle brush or a harder bristle brush can really do a lot of damage in a short period of time.
Okay.
And the idea behind a soft bristle brush is it allows the bristles to get up underneath the gums. And so if you're scrubbing back and forth, you're cleaning the teeth, but you're not cleaning the gums properly.
You're saying back and forth versus up and down?
Well, what you want to
mean?
do is angle the brushes
Angle.
into the gum and use a circular motion, so it can kind of clean things out.
Okay.
So somebody who has limited mobility, an electric toothbrush might help them to produce that motion a little bit better. There are also people that maybe have lost the use of a hand, or
Right.
I broke my arm for 3 months and I was relegated to using floss holders. So you don't have the use of both hands. I
Okay.
found them very frustrating. I don't understand how people think that's easier to use than regular floss. And
Do you think you might invent something someday?
well, that might be a good idea. I'm a little busy in my practice now.
I'm
but
sure
to be-
you
to
are
be
very
inventing
busy,
things
but
with that,
something
yeah.
like that, I mean,
Yeah.
there's a need.
Right.
You experienced it yourself.
But I also think there are other healthcare professionals, occupational therapists that are a great resource to patients. All aspects of their life when they're running against these roadblocks. But I will say I'm not a big fan of throwing more things into the equation. If I
Okay.
see a patient who is doing well, I don't recommend that they go out and buy a $100 electric toothbrush that has a $10 replacement brush head.
Oh, my heavens.
Or say a water pick. If somebody's getting the job done and they've got
Okay.
good oral hygiene, simpler is
Okay.
better. That's really where we want to be.
Okay.
But at times, it's definitely, the brushing and flossing is definitely not enough for some patients to
Right.
maintain their teeth properly.
Okay, so we're not talking about general population. You're talking for something like the electric toothbrush. We're talking about someone who may have a disability of some type.
That's correct.
Rather than the
Right.
general
Or
population.
the general population that somebody just isn't doing a good job brushing.
Or
So
they're
it
not
could be.
do-
It could be
Okay.
that we
Okay.
advocate for that. I personally use it myself.
Okay.
Of course, we get comped by the people at Sonic here in different places, so I have a never-ending supply of toothbrushes. But no, I really do like that product.
Okay. I don't know if this is on target with you or not. Are there certain types of foods that might be more difficult for people in terms of chewing, or that you say, this really might not be good? You have a problem with brushing, or you have a problem with your teeth. These foods might not be good for you.
Correct.
Is there something like that?
Yeah.
That we have
Well,
to be careful
and
of?
generally, we want to kind of limit the very simple sugars, because what ends up happening is, if any sugar, say for instance in a beverage, I mean, I like coffee, but I don't have sugar in it. Simple sugars, what happen is as soon as you ingest them, the bacteria in your mouth produce an acid that's very detrimental to the
my
teeth.
goodness.
Can break down the enamel more readily. But I don't believe in any bad foods per se.
Okay.
A lot of times when it comes to dental health, it's more the frequency of the consumption versus what's being consumed.
Okay.
And classic example I'll give patients is, years ago I used to have a coffee with cream and 2 sugars. Well, if you consume the coffee in say 10 minutes or 15 minutes, it's about 20 minutes after that your pH in your mouth is up and you're more prone to getting decay. Now,
Within 20 minutes.
yeah, that it's really raised. So we actually would not want someone to brush after having something like coffee for a good 30 to 60 minutes, because if you were to go to brush right after having coffee or say soda, the minerals, the enamel and the minerals are kind of demineralized and you're going to do more damage. So what you want to do is just kind of let the pH in the mouth settle down to a more natural level, and that's the big thing about salivary flow, is it actually buffers some of those negative things that we throw at our teeth on a daily basis.
Okay.
But getting back to the consumption, you might find somebody that has that same cup of coffee and they drink it over 3 hours in the morning. They keep going back and sipping it. Or a person that drinks their
Yes.
wine at night and they sip it for hours on end. And the problem you have there is it's the same amount of sugar that's been intake, but it's been in the mouth for now 3 hours plus the 20 minutes that it takes for the pH to buffer back to normal. So you've gone from someone that had 30 minutes of acidity to someone now has had 3 hours and 20 minutes versus acidity. So the effect that same amount of sugar is going to have is going to be real detrimental. But in terms of types of foods, we really try to caution people to watch out for things that are really acidic. The citrus foods are pretty problematic. The lemons, the limes of the world.
Really?
Yeah, they can really have a far-reaching effect in terms of breaking down the enamel than, say, some of the other foods. And yet, ingested with the meal, it's actually
with
not
the meal.
too bad.
That's different. I have a friend who starts her day every day with a half a grapefruit.
Yes. Yeah.
Is that not a good thing? Is that something I should be telling her?
Well, I think
she doesn't watch the program.
Well, I think grapefruit definitely is in that same category. I'd be more concerned with grapefruit in terms of pharmacologically. It can really affect the way in which some of the medications can be taken. I'm not a physician, but I know it can greatly increase how statins work, the cholesterol meds, and so grapefruit is a little bit challenging. But in terms of everything in moderation, I think is perfectly fine. There are actually some foods that are non-karyogenic. Some meats and cheeses actually have components that remineralize the enamel. They have calcium and phosphorus, right? So they're actually working to kind of build things up as opposed to breaking things down. So maybe some cheese with your wine would be helpful.
Okay. Cheese, crackers, wine? No crackers.
Well,
they
the
might
crackers
have sugar.
are the carbohydrates.
They
We're
might
going to have a problem with that one. But,
all right, then.
Yeah,
so cheese might be helpful.
Yes, definitely is. Yeah.
Now, there's this thing going on right now where milk might not be helpful for people, for some people. Is that?
No, that's a positive.
That's a positive. That's definitely a positive.
Yeah, and definitely, things like yogurt. But we're talking about plain yogurt. We're not talking about the yogurt that has, all the additives in it. Okay. Or the way I like it with honey. Now you're introducing that sugar back in there.
Okay.
And there are different types of sugars. Not all sugars are created equal in terms of diet. There are fruits, you might say they're fruit sugars, but the harder fruits that have a lot of water content, like apples and pears, are actually good for the dentition as kind of natural cleansing.
Okay.
And what minimal sugar they have is kind of neutralized by the fact that they're high in that water content. Same for celery and vegetables. I mean, you can eat those to no end. Nuts are also in the same category, that they're really not detrimental to the teeth. So.
Okay.
Yeah.
My goodness.
Yeah.
The pluses and minuses here. Right. Now, one of the people I was talking to last week when I was preparing for the program, she said something about no matter how much she brushes, no matter how much she flosses, no matter how much she tries, she can't get rid of bad breath. Now, is that something separate? Is that related to foods?
It could be
I don't know what
related.
it's
There are
related
a lot
to.
of things that can come into play with that. So usually with bad breath, I mean, I think most people are kind of cognizant. If you're having garlic and onions all the time, no amount of brushing is going to take care of that in the short term.
Right.
So this is overall dietary. Your friend or the woman you're talking to said that she's good on her oral hygiene. That's usually the biggest thing. People who haven't meticulously cared for their mouth, things kind of sit around. You've got this detritus that's sitting there that's kind of fermenting, for lack of a better word. And one of the big things we find with bad breath is it can be an indication of gum disease. I mean, I've had patients that come in for the first time, you smell this metallic scent, and it's almost like before you've done your assessment, you're pretty much sure of what you're going to find.
Okay.
Dental decay can also be, untreated decay could be a culprit. And another thing that can help in terms of lessening bad breath would be brushing one's tongue. Most everybody's good about brushing their teeth, but a lot of people don't brush their tongue. It's not the most comfortable thing to do. Some people it causes them to gag. But I always tell patients, if you brush your teeth and or if you just took a toothbrush after you've had coffee with no toothpaste on it and water and run it over your tongue and take a look at what's on that brush, you'd be surprised.
Oh my heavens, okay.
Yeah. And then if we kind of go through all of those entities, and there's something that we don't really find in etiology for, and there are some mouth rinses that are antibacterial that can be helpful as well. Then we'd want to bring a patient's physician in. Is there something else that's going on systemically? Right. Sometimes people who are diabetic can have a little bit of an off smell to their breath, and the reason for that is diabetics and people who are dieting, they can go into what's called ketosis. What happens is if you don't have enough carbohydrates that you're ingesting, your body converts to burning fats, and in the process, they give off ketones. So, that's the reason why I don't diet. I don't want to have bad breath in front of my patients. So.
Okay. Oh my gosh. I have three questions floating around in my brain right now.
I hope I have 3 answers.
You mentioned earlier something about dentures and people who come in who have dentures or they get dentures, then you don't see them again.
Yeah, a lot of times they
What
kind of
is
think it's a
that?
once and done. They feel as though, hey, I've got a complete set of dentures, and I'm done with the dentist. But really, dentures, if they fit properly, that's fantastic. But sometimes they don't fit well, and they can be more prone to causing sores and infections in the mouth. Over time, dentures may not fit the way that they fit, when they were first delivered. Believe it or not, some people find this shocking, but it's recommended that a new denture be made every 5 to 7 years, and I've seen 30-year-old dentures.
30-year-old dentures?
Yes, yeah, and there are people that are they're married to them, and they feel they're comfortable and they don't want to change them. But one of the biggest problems with somebody wearing a denture for that period of time is the denture teeth start to wear down, and what happens is it can affect the way in which your jaw functions, because now as they wear down, your muscles of mastication actually kind of change. So you get somebody who wears a denture for 30 years, finally, cracks, they need a new one, and now they want to show a full tooth. It's harder to get them into what they would like to see in the new appliance because their muscles don't open that much. And so that can be one of the negatives of wearing them long term.
And I would think weight gain or weight loss might change something too.
Definitely,
right?
Yeah. People who have weight loss, especially if they're going through a medical type crisis and it's dramatic, sometimes we have to see them to reline the dentures or somehow stabilize, and that can definitely have an implication in terms of the fit of the prosthetic.
Okay. Now, some seniors no longer drive cars, so they must perhaps have a ride. If they're not on a bus line, they're probably going to have a ride from a family or a friend member or one of the senior buses.
Correct.
Okay. Do you see a lot of that, or is that something that I'm only thinking about because I work with a specific population?
Yeah, we see a fair amount. I mean, we have some of the local services in the communities that the buses that bring patients, and we'll schedule those appointments for them in terms of when to pick them up and to drop them off. And but a lot of families, if somebody's in a nursing home setting, it's rare that we're seeing them in the private practice. But for a lot of families, if they're connected to somebody, definitely we're seeing a lot of seniors. But we're fortunate; we have a lot of dynamic patients in our practice. Believe it or not, nearly fully dentate that are 100 years old that come on their own accord.
Good for them.
Which is wonderful.
Yes,
and they're quite inspirational.
Yes, it is. Yes.
Yeah, and I try to glean what have been the steps that have gotten them to that point. And I have full access to their medical histories.
That's worth a book someday. What keeps them going?
Yeah. Yeah, they don't see an end.
They don't.
Yeah,
Good
the
for them.
90-year-olds that it's absolutely amazing. Absolutely amazing.
Well, there is such a thing as ageism, and we think perhaps people reach a certain age and they don't need something or they're not interested in something. Well, you're giving perfect examples how that's untrue.
Right, and I
Simply
think
untrue.
too, perception is an issue. I remember years ago, my grandfather was hospitalized towards the end of life, congestive heart failure, and I remember my mom, who was a registered nurse, taking a look at his medical record, and they wrote in the record that he was a malnourished, 80-some-odd-year-old man. Well, my grandmother was one of the best cooks in the world, and he never missed a meal. However, his morphology was such that he never had an excess ounce on him, which, but, the way in which somebody just looked at him and they said, well, he's emaciated. No, he was a healthy man. I think we're all used to, the society we live in where everyone has a little extra weight, but, their perception and what actually hit the record were two totally different things.
To write that in the record, too.
Yes,
Right.
yeah. But it was an assumption just based on a visualization.
Right,
right.
Oh my gosh.
Yeah.
Oh my gosh. We have to be careful of this.
Yeah.
We have to be very careful. We're going to be winding down in a few minutes, but again, I have questions floating around here. What if a family member or friend comes in and instead of waiting in the waiting room, they want to actually go in with the senior citizen. My druthers is to say, sit out in the waiting room, unless someone perhaps is incapable of making decisions. Do you see anything like that, or is that just something, again, because populations that I've worked with?
I mean, if somebody's fully cognizant, chances are, you know, it might be an impairment if they need the ride there, but most don't have a family member in with them. If there's something that I think is cause for concern, I might ask some of that.
Right.
And, you know, a lot of people will actually sign a release form that allows us to talk to them, even if they're not there. You know, there might be something where they say, hey, look, you know, maybe somebody's slipping a little bit, but they've already kind of said, you know, that's it. And we don't necessarily need a healthcare proxy, but they're a form that we'll usually use. But it's usually discussed with the patient far before we get to the point where, you know, if somebody can't make a decision on their own, then certainly the family member would maybe have a healthcare proxy. But most of my seniors are pretty independent.
Yeah.
They run their own show.
Yeah, good.
It runs into a little bit of a issue sometimes because you may find a family member, say a son or daughter, that's questioning why we're not doing something for their parent. And if we don't have a release, you know, it's the patient's decision as to what gets done. So.
That's right. Well, I think sometimes, well, we talked about it in a different dimension, but I think sometimes our children think we don't know what's good for us, okay? And I think sometimes they want to, they want to help. They want to help. It's not that they're being negative. They want to help.
Right, exactly.
And they might not know the right way to help.
Right, exactly.
Okay?
Yeah.
So, you know, these
The
things
senior
happen.
has a lifetime of wisdom. I usually put my money on them.
Yeah. So I didn't even ask you, how many years have you been practicing?
25 years.
25? You don't look like you're over 35.
Yeah, well, I'm a senior citizen. I just found out from you today because I'm over 50. I joined my father's practice. My father was Gregory Ross. He was practicing dentist for over 50 years, which is highly unusual. And yeah, so I had the honor and pleasure of working with him up till 4 years ago. He practiced right into his 70s, late 70s, I should say, which is phenomenal.
Yeah. So you followed in your father's footsteps, basically.
I did, and created a few of my own.
Yeah, well, I'm sure. Of course you did, because you're an independent senior. Of course.
That's right.
Like I said, we're going to be winding. Is there anything that somehow we may have omitted that you think is so very important?
Sure. I mean, one of the first things we do is we see patients. There are three kind of foundations for treating patients. There's medical history, there's taking dental radiographs, which are necessary to kind of know what's going on behind the scenes, and then there's the oral exam, which tells us a little bit of information. But a lot of people do ask us, you know, why is it that we're asking about, you know, the medications that they're taking? And there are a whole host of medications that really can have some serious consequences on dental treatment. The biggest thing I like to find out, first of all, is anyone has any allergies. A lot of times if we're treating dental infections, you know, we certainly don't want to prescribe an antibiotic that patients had a problem with, or a painkiller. Something as simple as aspirin over-the-counter med can be, you know, problematic, so we'd have to avoid it. And as seniors age, they're more likely to be taking medications that can cause dry mouth, and any of the anti-meds are usually implicated with that, meaning anti-anxiety meds, the antidepressive meds can really dry the mouth out, and all those things can really adversely affect the teeth.
Then. Okay.
Yeah, so
there's a lot. There's a lot to consider.
Right.
Okay. What about insurances, just in brief, because we're really winding down. Most insurances really aren't paying very much for seniors to have their dental care.
No.
So they need to know this ahead of time before they're retiring,
Correct.
in other words.
Correct, yeah. A lot of them may have had some insurance, dental insurance within the job world. But I always tell patients, most people, unfortunately, even that have insurance, is usually about $1,000 a year. And it can go a long way towards the basics, but it doesn't insure for a more profound loss. And in retirement, there has not been a plan that I've ever seen that really benefits a patient.
So basically, try to plan ahead.
Correct.
Okay. I want to thank you so much for coming
pleasure.
today.
Thank you very much.
Thank you for this information, and I'm sure our audience appreciates this as well as I do.
Yeah.
Okay.
It was a pleasure.
Thank you for watching, and until the next time, take care, everybody.
For the Young at Heart is sponsored by Duville Life and Wellness Community, a commitment to care, a legacy of compassion. This is